So this is a lecture that that I discussed with my colleagues who are going for the FRCS exam, in the international FRCS exam, and they were querying about the neurosurgical roads in UK. And as Hassan mentioned, there is few alternative ways. So not everyone who's working in the UK is a UK graduate. So if you are a UK graduate, you go directly to the GMC registration following the F1 graduation. If you are non-UK medical graduate, which is most of us, so either you are European, then you follow another route, or a non-European, and then you have to do the PLAB, and then you do a 2-year fellowship, foundation, to be approved as a graduate, and then you go through the training way. So the training way is divided in the surgery into either core training or junior training program with ST1 to ST3, and then the middle grade, then the senior grade. For the surgeon, I don't think you need to do the MRCP, Hussam, or MRCP psych in the medical subspecialties, but in the surgical, before you step up to the ST3 or ST4, you need to do the exam. So you need to do the membership exam, which is the MRCS. Lots of people in Egypt, for example, they call it fellowship. So they call it Zamala. It's not fellowship, it's a membership. So it's Adwiya. Just to clarify things, if you are calling it fellowship just to put it on your clinic, that's fine. But for the registration, it's called membership. By the end of the training, you're allowed to apply or to enter the exam at the level of ST6. And after the exam, you could finish all the paperwork to finish the CCT. That's a training route. But the alternative routes that I will be talking about, this is my experience because this is what I've been through. I haven't been through the surgical training. So you could enter not by BLAB, as most people know. So you could enter with MRCS followed by OET or IELTS. Recently, they opened the international FRCS, so the Fellowship Royal College exam. And we'll talk about this in the fellowship route, plus OET. So you need the OET. I think previously some hospitals used to sponsor the language. I'm not sure if that's the case anyway. I think everyone has to do the English test, including the UK system, the European trainees, and the ISTP or MTI, as Hussam mentioned. I'll just run through this list quickly because this is very important. In any subspecialty you're going through, you've got some committees that you need to be aware of. For the surgical committee, you need a GCST. So this is the committee that will grant you with either CCT or a CESR. So this is the communication between you and the Royal College. And they call it the joint committee. It includes general surgery, orthopedic surgery, neurosurgery, cardiothoracic surgery, etc. Then if you're going for the exam, you need to be aware of the Joint Committee of Intercollegiate Exams. So this is the exam that you do in the UK. So this is the UK exam. And the alternative is GCIFE, I think, which is the international exam. You need to be aware of the General Medical Council and all their rules and good medical practice. The subspecialty society, so this is SPNS, for neurosurgery is surgical, so Society of British Neurosurgeons. And for any surgeon, you need ISCP, so Intercollegiate Surgical Curriculum Program. So this is where you record all your progress and your work-based assessment by your colleagues and by your seniors. Well, so this is the flow chart of the training and the alternative training. And as I mentioned, so you flow through ST1 to ST8 or CT1, CT2, ST1 to ST8, during which you do the MRCS exam, then followed by this at ST6, we do the FRCS exam. At the end of the training, you are granted either CCT or CESR. And the CESR, you need to qualify to the CESR in a CCT equivalence. Then you could apply for a consultant role. So the certification here is just to give you the eligibility to become a consultant. Some would consider it as a consultant level certificate, but it's not a consultant title. So that having a CCT doesn't mean that you are a consultant. So I can't identify myself as a consultant just with a CESR or CCT. That means I'm eligible to become a consultant. So that's very important terminology as well. During your training or your equivalent training, including CESR, you need to identify the curriculum. So the difficulty of being, of finishing the CESR is that you have to run this curriculum the opposite way. So you're not going from the left to right, you're going from the right to left. So basically, you're starting from the end and you collecting everything in retrograde manner. So thinking about doing an ITU because you haven't done ITU in your training, so you go back to ITU. You need some sign off for neurology or radiology. You need to go back for radiology. The trainees does this as ST1, ST2, but you are thinking of it as a pre-consultant level. So you need to think back of what you need. This is the difficulty of the CESR or the alternative route. But some people who's coming for I did this myself. So I usually plan my life. On day one, I started as an SHO and I knew exactly what I need to do. So I had some sign off from my seniors in ITU, in radiology and in neurology for the competencies that are required for the CESR. And that's what you need to think ahead. So don't think backwards. Otherwise, after 3-4 years in the country, oh, now I'm settled, I finished my visa, I think about the CESR. No, this is not how it works. It works other way around. So you need to think of the CESR the day you enter the country, or maybe even before you come to the country. Every training has got different competencies that you need to fulfill based on what specialty you need. So either general competencies, including putting a cannula or assessing a patient or examining or even consenting a patient, up to a special interest competencies, including doing a skull base, vascular, renal, whatever you want to do is the special interest. And by the end of the special interest competencies, you're signed off for eligibility for the certification. So lots of routes that you need to understand. And it will confuse you if I go through, but this is what you need to be certified in the UK. The other thing about this that I probably want to highlight is the workload, and I think Dr. Mahmoud Rabi will comment on this because he's seen the overview of the situation now outside the NHS. So as an example, in neurosurgery, in 1990s there were 150 neurosurgery consultants in about 30-35 units. Currently in 2020 there are 453 neurosurgery consultants. There are more trainees graduating from the CCT than they're required as a consultant. So this is the market that you need to be aware of. So following your CESR or CCT, you need to read the situation. And it's a bit disappointing in neurosurgery specifically because we have about 50 post-CCT trainees with no consultant jobs traveling around the country. So basically they're doing either trust grade jobs or fellowships. And I've been one of the luckiest because I thought I will be one of these 50s. And in 2028, there will be 100. So the calculation of the progress of this situation is to be 100 waiting for a consultancy job by the 2028. And they started to work on this by reducing the training numbers. So the training numbers in neurosurgery dropped from 35 to 14 last year. And I think they will drop it down further to control this. So they're increasing the trust grade. So for the people who are coming from abroad, it's a good news because you can join the country easily. But the problem is the exit is the problem. You may not be able to exit the training. You can get the CESR, but you can hang up in the country for a little bit while. And this is just flowcharts of the most recent workload assessment of the SPNS. So in every society, you will find these calculations, and they will tell you the workload and the requirements in different subspecialties. So if you are junior and newly graduate, you need to think ahead of how the situation will be. Is it easier to get through the training or into the training or out of the training? So this is how you plan your life ahead.